We're going to take a look at disorders of systemic arterial blood flow. So there's two definitions that we want to know as we move forward. Ischemia, which is a decrease in arterial blood flow, leading to oxygen deprivation of the tissues. And an infarction. An infarction is a blockage of an artery or vein that causes ischemic necrosis or tissue death. So a lot of people are familiar with the term myocardial infarction, which is a heart attack. That's when generally an artery gets blocked in the heart and we have death of our cardiomyocytes. You can have infarctions in other tissues. So for instance, a pulmonary infarction can be caused when a blood clot gets lodged in the lungs, and then we have death of pulmonary tissue. The first arterial blood flow disorder we're going to take a look at is dyslipidemia, which is a metabolic disease characterized by abnormal levels of lipid in the blood. The most common form of dyslipidemia is hyperlipidemia, or an excess lipids in our bloodstream. It's important to remember that lipids, fats, fatty acids, triglycerides, and cholesterol, these are all important molecules that are involved in physiological processes. Sometimes we vilify them, and you'll hear people be like, oh, it's a bad fat, or oh, cholesterol is all bad. No, if there are too few or too many of these nutrients, then it can cause pathology. But remember, we do need these lipids for our physiological processes. We just need them in the right amounts. When we discuss fat and cholesterol in the body, we have to understand how it's packaged and transported throughout the body. So fats are hydrophobic, and they would clump together if they were freely floating in the bloodstream. So they get packaged into water-soluble boxes that are called lipoproteins for transport. So here's a lipoprotein. It has a hydrophobic core, and that's where the cholesterol, triglycerides, fatty acids, and the tails of our phospholipids are going to be. And surrounding the core are what we call apoproteins and the phospholipid hydrophilic heads. And so it makes this vesicle, and this vesicle then is water soluble. The types of apoproteins present in the lipoprotein will determine its density and what cells and molecules will interact with it. So these apoproteins have a very specific job. If lipoproteins are centrifuged in a tube, like right here, they're going to separate out based on density, and that's how we name them. So the lowest density lipoproteins have very little protein. The first one that we're going to look at is called VLDL, for very low density lipoprotein. These VLDLs are involved in transporting triglycerides from the liver to the body's cells. LDL stands for low density lipoprotein, and these have a high amount of cholesterol and more protein than the VLDLs. These are the main transporters for cholesterol to the body's cells. So they bring cholesterol to cells that might need it to be able to repair their membranes, or maybe the cells need it for steroid synthesis. Cells that need cholesterol are going to put LDL receptors on their surface. The LDL binds and the cholesterol will be added to the cell. Phagocytic cells like macrophages and monocytes can also scavenge and phagocytose the LDL. They do this if there's an excess of LDL compared to the available receptors. LDL is also referred to as bad cholesterol because high levels of it are linked to cardiovascular disease. As I stated previously, that scavenger pathway where our macrophages can phagocytose excess LDL, those macrophages can be in arterial walls, and that can then cause atherosclerosis or a plaque. The plaque can then increase resistance in those blood vessels, and an increase in resistance increases blood pressure, and that then affects the flow of blood. HDL means high density lipoprotein, and these lipoproteins bring excess cholesterol back to the liver where it can be eliminated through the GI tract. These have the highest density because they have the greatest amount of protein and the least amount of cholesterol. So that's why they can sort of scavenge, pick up excess cholesterol for elimination. We relate HDL to having a protective effect because it lowers the risk of arteriosclerosis, and then it lowers the risk of cardiovascular disease. So this image explains how lipoproteins are involved in lipid transport. So triglycerides and cholesterol get ingested by our GI tract. So we eat them, we take them in, and they're placed into chylomicrons and get transported to tissues that need them. So they can move to adipose tissue to be stored, or muscles that can use it for energy. The liver also stores a lot of cholesterol and triglycerides for us. LDL gets sent out to the body's cells to be able to deliver cholesterol. So here's LDL. You can see it's packed full of cholesterol to deliver. If it finds cells that have LDL receptors present, it will bind. Those cells are putting out that receptor because they need the cholesterol, and that cholesterol will be taken up by those cells. If there's an excess, then that scavenger pathway where we'll have phagocytosis of the excess LDL, and that might lead to pathologies. We also have HDL then that is scavenging and picking up excess cholesterol, and it brings it back to the liver where it can then be eliminated via the GI tract. So our first pathology then that we're going to look at is dyslipidemia. And there are two categories of dyslipidemias, primary and secondary. Primary forms come mainly from genetic mutations, and they're not caused by other diseases. The genetic mutations can lead to an excess of cholesterol because the apoproteins can be decreased, and there can be a lack or defective lipid receptors. So cells do not take up cholesterol properly, or the cells don't handle the cholesterol properly. Primary dyslipidemias are very rare. We can also have dyslipidemias that are secondary, and these are caused by another underlying condition. So those associated with hyperlipidemia include a diet high in animal fats. So animal fats contain cholesterol. Plant-based foods generally do not have cholesterol in them. Why that matters is because the liver produces the cholesterol that we need for our body's physiological functions. So if we consume excess cholesterol, it raises our body's cholesterol then. Other things associated with hyperlipidemia include obesity, type 2 diabetes, hypothyroidism, obstructive liver disease, and certain drugs. The mechanism here is going to be slightly different for the different causes, but they'll all eventually create an excess of high cholesterol. Hyperlipidemia is normally asymptomatic, but it does lead to our next pathology, which is atherosclerosis and plaques that develop in our arteries. So atherosclerosis is a hardening of the arteries that occurs because of a plaque buildup from hyperlipidemia. The plaque decreases the diameter of the blood vessel. So if you compare this nice open lumen to one that has a plaque in it, we can see that there is a great decrease in the diameter here. That decrease in diameter increases resistance and reduces blood flow. Additionally, that, quote, hardening of the artery means that it has a decrease in elasticity. And so it will have decreased ability for vasomotion, which can hinder the hemodynamics. So atherosclerosis is a multifactorial disease. There's many risk factors that can be associated with the disease. Hypercholesterolemia is a hyperlipidemia, older age, being of the male sex, having a family history of cardiovascular disease, genetics, being postmenopausal for women, smoking, obesity, having hypertension or high blood pressure, and being diabetic are all risk factors. Some of these risk factors are additive as well. So meaning if you have more than one, it's going to increase your likelihood much more so. The exact etiology of atherosclerosis is not well understood, but the accepted theory is called the response to injury theory. So the first step of the response to injury theory is that the endothelium of a blood vessel becomes injured. And this can be from inflammation due to immune mechanisms, high cholesterol, smoking, hypertension, etc. So macrophages are going to come, here's our macrophages, they're going to come to the area of that injury and move into the tunica interna. Once they're here, they tend to scavenge excess cholesterol and pick it up. So remember, the jobs of these cells is really they're part of the immune system. They're phagocytes. So within them, they have high levels of reactive oxygen species or free radicals that break down whatever they phagocytose. So they oxidize the LDL, and these cells accumulate LDL. And when they do, we call them then foam cells. Oddly, this is helpful because it decreases excess cholesterol from the circulation. However, the foam cells will release many different factors that further injure the endothelium in the blood vessel. With time, the foam cells will keep collecting and form a lesion in the blood vessel wall. So here you can see is a foam cell, and now we have a lesion here. The macrophages secrete growth factors that cause smooth muscle cell proliferation. So here you can see is smooth muscle. Eventually, the macrophages die and they leave behind their necrotic debris, and we start to accumulate lipid then. And now that's going to start to generate our plaque. So the lesion generally has a smooth muscle cap that covers it. There's also extracellular matrix formation. And remember, this was started sort of by inflammation, and those macrophages were originally immune cells. So we're going to have an accumulation of leukocytes in the area and also lipid. So here you can see is that necrotic core. We do have those foam cells still present. Here's our fibrous cap. The lesion itself is going to start to narrow and harden that artery. So we'll be affecting blood flow and blood pressure, and it's increasing resistance. If this lesion or plaque ruptures, it can cause a hemorrhage or a thrombosis. So in this image, we can see sites of severe atherosclerosis in order of frequency. So you can see, we see it a lot in the abdominal and aorta, iliac arteries, in the coronary arteries, our thoracic aorta, femoral popliteal arteries, the internal carotids, and then in the vasculature in the brain. Narrowing of the blood vessels can cause ischemia. In the heart, that's detected as angina. In the nervous system, we can see what we call transient ischemic attacks. In the periphery, there can be intermittent claudication, which is a cramp in a limb when it's used. We can see impotence, wounds or infections might not heal as well. It can also cause obstructions in vessels from hemorrhage or rupture of the plaque, and that can lead to a thrombosis or an embolism. We can see aneurysms, which is where a wall of the vessel is weakened and it then can balloon. Atherosclerosis leads to our next disease, which is hypertension or high blood pressure. The issue with high blood pressure is that it's a risk factor for cardiovascular disease or CVD. Hypertension makes it 4 times as likely for a person to die from a stroke, 3 times more likely to die of heart disease. According to the CDC, 69% of people who have their first heart attack, 77% of people with their first stroke, and 74% of people with chronic heart failure all have high blood pressure or hypertension. Those are startling numbers. But what is really shocking then is to consider that 1 in 3 Americans, or 33%, have hypertension, and it leads to almost 1,000 deaths per day. There are 2 categories of hypertension, primary and secondary. In secondary hypertension, There's an underlying disease that affects the heart, kidneys, or endocrine system, and thereby influences the blood pressure. Illegal drugs like cocaine, amphetamines, or prescription drugs that mimic the sympathetic nervous system, and also oral contraceptives can also cause secondary hypertension. Thus, secondary hypertension is seen in people under 30 years old and above 50. Here, we're going to examine primary hypertension, which is more common, and it affects 90 to 90% of adults who have hypertension. It occurs without a causative clinical disease. There are two types of risk factors associated then with primary hypertension. The first group is considered non-modifiable risk factors, or risks that someone cannot change or address. For example, we cannot change our age, and with age, there's an increase in risk of developing hypertension. Gender is another non-modifiable risk factor. We see that men are more likely than women to have hypertension. However, women are more likely to succumb to the adverse effects of hypertension, more so than men. Race is another risk factor, as African Americans have more prevalent and severe disease compared to their white age counterparts. Family history is another non-modifiable risk factor. The disease does seem to reoccur in families, but whether this is a genetic or environmental factor is very difficult to distinguish. And lastly, genetics can play a role. There have been different genes associated with high blood pressure. There are also modifiable risk factors. Since these can change, patients are always encouraged to decrease these risks as much as possible. As you will see, the modifiable risk factors are linked to lifestyle and they are interrelated. So these can include dietary factors, diets that are high in sodium or salt, calories, sugar, saturated fats, or trans fats are associated with high blood pressure. Dyslipidemia or hyperlipidemia is also related to diet, and so consuming saturated fats and cholesterol can cause dyslipidemia. As we've previously seen, hyperlipidemia can lead to atherosclerosis and hypertension. Obesity or being overweight also leads to high blood pressure mechanisms, and it leads to other risk factors like insulin resistance, type 2 diabetes, and obstructive sleep apnea. Tobacco and alcohol consumption are linked to hypertension as well. Fitness and exercise have been shown to lower blood pressure, and it helps to decrease weight, lipid levels, and it also decreases risk for type 2 diabetes as well. So exercising and staying in shape is a great preventative measure. Hypertension is a progressive disease, and it does not present symptoms at the beginning. As we can see, prehypertension, due to increased cardiac output, can even start in childhood. And with time, it becomes early hypertension due to increased peripheral resistance. Eventually, it becomes established as hypertension, and then it becomes complicated hypertension, in which now there is organ damage being done. And that's generally the heart, brain, and kidneys that we first see organ damage. The etiology of primary hypertension is multifactorial, and it includes both genetic and environmental causes linked to those risk factors that we mentioned. We know hypertension is tied to physiological controls of blood volume, cardiac output, central nervous system stimulation, blood viscosity, and blood vessel elasticity. So those are the things that affect blood pressure. However, the exact mechanism is unknown. Research has indicated that the mechanism might be immunological in nature. And one theory is that oxidized lipids act like a new type of antigen, and they trigger an immune response in the kidneys and in the blood vessels. The clinical manifestations of hypertension depend on the end organ damage. So for the heart, this can be angina because of ischemia, a myocardial infarction or heart attack, and heart failure. In the brain, if it's affected, it can play out as a stroke or a transient ischemic attacks, where there are symptoms of oxygen deprivation to an area of the brain that's being affected. The kidneys can be affected by disease or failure. There can be peripheral artery disease, which affects the arteries outside of the heart and thorax. Retinopathy can occur, which can lead to blindness, and we can see sexual dysfunction in patients. So there are different stages of hypertension based on the actual systolic and diastolic measurements, and they have varying levels of severity and treatment options. Hypertension is treated with drugs aimed to decrease water and salt in the body and thereby decrease the blood volume and blood pressure. Diuretics work to increase urine excretion. There are also drugs that can disrupt the RAS system, or the renin-angiotensin-aldosterone system. These will decrease water retention and also cause vasodilation. And beta blockers are a class of drugs that block the input of the sympathetic nervous system. So this will cause vasodilation and also decrease the contractility and workload of the heart and thereby decrease blood pressure. And that concludes our discussion of the disorders of the systemic arterial blood flow.